Thank you, Ayush. So, thank you so much for letting me talk about this important topic, right? So, we are going to talk about, how you are going to look at the retinal vasculature and the choroidal vasculature, right? So we are all used to know this thing. Like we have, a capillary bed, the arteriole, capillaries, venules, and veins. So certain few things we need to know before we are going to talk about this. Say we always talk about this inner retinal barrier and the outer retinal barrier. So inner is the blood vessels, the retinal microvasculature, which have the tight junctions. In certain conditions, these tight junctions can get affected, leading to leakage. That's one. And then we need to know that the certain areas of the retina, we have, not just one layer, there are multiple layers of the blood vessels. And then the outer retinal barrier is basically your pigment epithelium. And then under that, you have the choroid. So just under, you have the choriocapillaries with extremely leaky vessels. And another thing I want to just highlight is that the retinal pigment epithelium and the Brooks, they share emission properties similar to very similar fluorescein properties. So, like the fluorescein angiography is not really useful to image anything beyond RP. So, having all that in your mind, let's move to the next slide. So, we actually have looked at the patient and have a clinical diagnosis. And why we want imaging is maybe we have a working diagnosis already, we want to confirm it. Or we have a list of DTs which we want to shortlist. Or maybe we know the diagnosis, but we really want to stage and grade the disease so that we can decide what we are going to do, what would be the outcome. So basically, what are we going to look at in imaging? So we want to see, whether there are any occluded vessels and whether there are any dropouts, or are there any vessels which are leaking? Do you see any new blood vessels, microaneurysms, macroaneurysms kind of, or maybe specific to certain diseases like polyps? You want to differentiate always, are they collaterals, ERMA, or are they new vessels? Or maybe in certain cases we want to see whether there are vessels associated with another pathology like malignancy, or maybe in addition to all these, sometimes we look for certain characteristic features or staining patterns, right? So having all that in your mind and also having a working diagnosis, we need to go. Otherwise, your exercise is going to be useless. So what you see on the top is polyp ICG, and then second picture you see the areas of capillary dropouts and enlarged avascular zone, and the bottom you see a OCT A, where you see the again capillary dropouts, but in addition you see vascular signal where you see the new vessels breaking through the internal limiting membrane. So what we are going to talk about, these imaging modalities, actually they are complementary. Like sometimes you may need to do few, not just one, but wise use of whatever the available modality is the way to go. So let's just talk about the fundus fluorescein angiography for the juniors. You inject a dye and just see whether there is a fluorescence. All right. So, so normal fundus fluorescein angiography, say you take as injection at 0 and 9.5 seconds, you will see the posterior ciliary arteries, and then 10 choroidal flush, 10 to 12 seconds, you will see the retinal arterial, and then capillaries, so on. Like say 20 seconds, the angiography, first circulation is over, and then recirculation happens 3 to 5 minutes after. So it happens so fast, like in 20 seconds, it's all gone. All right. Say after 10 minutes, you don't see any fluorescence, it's all washed off. So what we should know is, like, everything should happen pretty fast to detect anything useful. All right. Yep. So, but it's really, look at the pictures, it's very physiological. The dye enters into the arteries, then go to the capillary network, then go to the veins, then washed up. So it's what we know as a circulation, right? See, arteries, goes to the veins, kind of. So we are used to this pattern of thinking. When we were registrars, we were doing a lot of fluoresceins, and we are supposed to be able to do fluoresceins, taking pictures. But I don't think any new registrars are doing those. Why? Because certain other easy decision making can be done by OCTs and OCT angiography. So we have very low threshold. Like we are doing fluorescein at a very low rate. Why is that? Because we are worried about the complications. So a lot of patients end up in, like a fair percentage, nausea, vomiting, and pruritus, kind of things, pyrexia. So look at the rate. It's could be like 7% of your patients can end up in vomiting. So we have seen that. So, something which happens in 10 seconds or 20 seconds, if your patient starts vomiting, you are finished. And then you will lose all the details. And also, very rarely you have these life-threatening things like anaphylaxis, cardiac arrest, broncho. So you have to have a trained nurse, emergency trolley on your imaging room. And death, though extremely rare, it happens. So because of that, we tend not to do many fluoresceins today. So you have to have a very good photographer and a very cooperative patient. Even your patient is cooperative. If the patient starts vomiting, how can he maintain the fixation? So the patient has to have fairly good vision to maintain the fixation. Otherwise, again, you are in trouble. And also, like say somebody who has pathology in both eyes, it's extremely difficult. Once you finish one eye, when you go to the other eye, it's all gone. Like 20 minutes, 20 seconds, everything has happened. And also, say for follow-up, if you want to do a few more, it is not possible. So you do a fluorescein today, you can't do it tomorrow. So there are a lot of limitations with the fluorescein, though it's a very useful test. ICG actually almost same thing with the fluorescein, but it actually images the choroid. So because of the dye and the spectrum we use avoids RP, so that you will be able to look at the underlying choriocapillaries. And the binding capacity of the drug helps us to limit the leakage. If you really want to look at the choroid, then certain diseases we need to have a look at the choroid. So ICG is a must. So maybe certain situations we do ICG, FFA together. And now those days, current era of course limited, but those days we used to do a lot of ICGs and fluoresceins, because it was a requirement to classify what type of CNV is this in our register days, whether it is type 1, type 2 or type 3, because your treatment depend on that. But today you probably don't need, and certain things but still need, because like say PCV, you need to identify polypoid lesions and branching vascular necrosis. So that helps whether you can manage this with anti-VEGF monotherapy, or whether you want to do any add PDT. Like say in AFD, of course, maybe type 1 CNVs, because type 1 CNVs sometimes you see repletions like 25%, and which you can miss otherwise. So this helps your decision. Certain diseases have very characteristic ICG features, like especially if you have a case where you are looking for the, have a working diagnosis of white dot syndromes. They all have different characteristic features. So ICGs probably still something which we really need, say in white dot syndromes. Something you should know, ICG and iodine allergy is something you might appear in a MCQ maybe. So if you have a patient who has allergy to iodine related drugs, better to avoid it. And because we are giving a fairly high dose of iodine, like 840 micrograms, uncontrolled hyperthyroidism patients can go into stone. That's something you should know. But immunogenicity or allergic reactions are much less, because your radio contrast and all the others, it's a big molecule which is immunogenic. But whereas in the ICG angiography, what use the iodine is just to stabilize the solution. It's a small molecule, so it's probably not going to do much in allergies. The one thing about the fluorescein and ICG, we always talk about pregnancy as a contraindication, but there aren't big side effects as far as the pregnancy is concerned, but it's always mentioned as a contraindication. When you talk about the allergies and ICG, they are very rare compared to the fluorescein. All these are, like we talk about like 7%, 10% in fluorescein, but in ICG it is less. But still, anaphylaxis, cardiac arrest, those things can happen, bronchospasms. Roughly 1 in 300,000 death, but these are, extremely rare things. But you should always have your emergency trolley ready. So now all these things were introduced to ophthalmology in 1960, 1970, like say 50 or more than 50 years now. So OCT angiography is the new kid, which was really introduced in 2015. So just less than 10 years. But if you look at how many publications and how many articles on this, it's massive. So because OCT is practically easy to do in a clinic setup, the basic advantage is that you don't need it is non-invasive. You don't need a fluorescent material or something, a contrast material to help see. So it is just a basic OCT with moving red cells. We are trying to, the only moving particles on the retina is the red cells. So you are just looking at the red cells. But one thing we are missing here is, usually in a retina, when you want to look at the red cells, and you want to see whether any fluid leaking from the retinal vessels. But the OCT angio is not going to help you with that. So OCT angio will show you the movement of red cells, but not the fluid moving in and out of the blood vessels. So that is the part we are missing. Okay. One of the other things, I at the onset I said the retinal vessels in certain areas are organized in layers. So OCT angiography has the advantage of looking at different layers. Like this is really important when you talk about the diabetic maculopathy, where you look at the deep and superficial capillary plexus, and that gives a lot of information regarding the patient's prognosis, kind of. No other either fluorescein or ICG won't be able to show that. You can, it's non-invasive, so you can do eyes, at different times, so there's no issue with the time. And the limitations, the field is very limited. That's the biggest disadvantage. So you can just see the posterior pole, and you will never see arteries versus veins. They are just all vessels. And in conditions where you want to look at the leakages, like CSCR, CNVs, polyps, you will not see them. Thank you.